Well, good morning, everyone. Welcome back to the second day of the second annual Patient and Family Conference hosted by CancerCare Manitoba with support from the CancerCare Manitoba Foundation. My name is Dr. Donna Turner. I'm the Chief of Population Oncology, which is a part of the leadership team at CancerCare Manitoba, and I'm really pleased and excited to be here as your moderator for today's session. CancerCare Manitoba provides health services across Manitoba on the traditional land of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples. We acknowledge that Manitoba is also located on the homeland of the Red River Métis, and northern Manitoba includes lands that were and are the ancestral lands of the Inuit. CancerCare Manitoba acknowledges that colonial practices and policies have impacted the health and well-being of generations of First Nations, Métis, and Inuit who continue to experience inequities and obstacles in accessing healthcare, including cancer services along the cancer continuum. At CancerCare Manitoba, we respect the spirit and intent of the treaties and treaty making and remain committed to working in partnership with First Nations, Métis, and Inuit peoples in the spirit of trust, reconciliation, and collaboration, while also improving cancer control and outcomes for all Manitobans. One of the things that I think is really important when we do a land acknowledgement is also to reflect on our own personal journey. And so one of the things that I do when I either hear or share a land acknowledgement is to take the opportunity to reflect on my position and privilege as a white, educated, well-supported woman with European settler roots. I recognize that I continue to have advantage and opportunities while others have been and still are disadvantaged. I'd like to share just for a minute my own examples of actions towards reconciliation. For example, in my work as a member of CancerCare Manitoba's leadership team, I work to engage and respond to Indigenous voices in cancer care planning, service delivery, and evaluation. And I also look for opportunities to educate myself in an ongoing way and to support my staff in their educational journeys. All right, let's go to our first presentation of the day. I am really pleased to introduce our first speaker for today. Jodi Hyman is a nurse educator with the Systemic Therapy Program and the Community Oncology Program here at CancerCare Manitoba. And Jodi will be presenting on Unravelling the Mysteries around cancer and cancer staging. So I'm going to hand it over to her, and I'll come back at the time of the Q&As to help with your questions and the discussion that we'll all have with Jodi. All right, so we just need your slides up. There she is.
Good morning, everybody, and thank you, Donna. So I just wanted to start by saying that I am so happy to be here, and it is my second time presenting at this conference. I've been an oncology nurse for 28 years, and I couldn't think of anything better to do. I think it's just a fascinating area of nursing, and there's so much progress and so many things that we've been able to accomplish as a whole over the years to make the cancer patient journey that much better. So today I'm going to be presenting on, I will just bring up my slides, but I am presenting on what is cancer as well as cancer staging. So if you just bear with me for 1 second, I will bring up my presentation and we'll go from there. Okay. So unraveling the mysteries around cancer and cancer staging. So as part of this, we are asked to do an equity commitment. So that means in preparing for this presentation, I've considered health equity resources for presenters provided by the Conference Planning Committee. This was provided to help presenters reflect on how these topics and contents can have good effects and bad effects on people or populations that are underserved. So today, my topics are fairly, I guess, scientifically based. So these topics are suitable for everybody. So at the end of the presentation, I'm hoping that all of you will be able to have a basic understanding of what cancer is and how it develops, verbalize a few processes required in confirming the diagnosis of cancer, and to be able to understand what staging is and why it is important. So I thought I'd start with a few definitions of cancer. So everybody has heard lots about cancer from the media, from your own lives, from friends, etc. But what actually is cancer? So there's lots of different definitions, all of them being reasonably similar, but I've picked two to be able to share with you. So the first one is from the World Health Organization, and this is from 2015, and it tells us that cancer is a genetic term for a large group of diseases that can affect any part of the body. Other terms used are malignant tumors or neoplasms. I also had a look at the Canadian Cancer Society, and they said that cancer isn't one disease, so that is similar to the World Health Organization, but it's more than 100 diseases. And depending on how you classify cancer, you can even say that there are more than 200 different types. So, what actually is cancer? So, if cancer can be 100 or 200 different types of diseases, what makes it actually classify as a cancer is the way that the cells behave. So, we know that cancer cells are abnormal. So, what does that mean? So, that means that they don't carry out their intended function. So every bit of our body is made up of cells, and each of those cells are have the genetic material and within them to say, hey, you need to function as part of our skin, you need to function as part of our heart, you need to function as part of our kidneys. But we know that cancer cells may not carry out their intended function. We know that they're uncontrolled. They do not adhere to normal rates of growth. So, cancer doesn't actually grow faster than normal cells, but the problem is they don't stop growing. We know that with normal cells, once I have, say, a layer of skin, then that's fine. My skin stops growing. You have a natural balance of skin cells that are dying off and new skin cells that are being born, but it keeps it in check. If you have a cancer, the cancer cells don't know when to stop growing. So they keep proliferating, which means multiplying and dividing. And therefore, that's how you end up with a tumor. The other thing is that they're able to spread throughout the body. So, one of the things with benign tumors is benign tumors do not spread. Where when you have a cancerous tumor, it has the ability for those cells to be able to break off, travel through our body, and set up home and start growing somewhere else. So when it does spread to different organs, it's called a metastases or metastatic spread. But to actually be a metastases, the cancer cells need to be from the original tumor, which is often called the primary tumor, and they must be found in a new location, which is a secondary site. An example would be if someone has breast cancer and the breast cells broke off from the tumor, they traveled throughout the body and they were found living in the bone. Or, for example, if you had colon cancer and you had colon cells living in the liver. It is actually possible to have two primaries. It's not that common, but it definitely can occur, which means that you would have two different cancers growing in you at the same time. But as I said, to actually be a metastases, you would need to have those breast cells actually growing in a bone, in a liver, etc. The most common sites for metastases is our bones, our liver, our lungs, and our brains. So how is cancer diagnosed? So there is no single test to diagnose cancer. In most situations, a biopsy is the best type of test to diagnose cancer. So there's different types of biopsies, but a biopsy is when a doctor takes a sample of the cells, tissue, or fluid and examines it under the microscope to look for defining characteristics of the cancer. So this would be someone known as a pathologist. So they're a doctor that specializes in looking at different types of tissues. When they put it under the microscope, do the cells look less organized? Are they abnormal? Do they have different sizes and characteristics? They can also use types of stainings and different tests to be able to see exactly if it is a cancerous tissue or if it's not. So, for types of biopsies, there's incisional, which basically removes a small wedge of tissue from a large mass. There is a core biopsy. So, that's when sort of like a large bore needle, I guess, or you would have almost a bit of tissue is inserted and a chunk is taken out, and then that's examined. Bone marrow is used to diagnose hematological cancers. So, with a bone marrow biopsy, that's traditionally used for leukemia. Other people that will have it would be myeloma, may have bone marrow biopsies, and lymphoma. So for that, they're able to put a needle into people's hips, so specifically into your iliac crest, and to suck out bone marrow, which actually looks very similar to blood. And then from there, again, they're able to put it under the microscope, do some different tests on it, some different stains, and then the pathologist is able to make a diagnosis. A sentinel node biopsy is used as a standard of care for breast cancer and for some melanoma. So, melanoma is a type of skin cancer. So the sentinel node biopsy, so anyone that is being worked up anywhere in Manitoba, as I said, this is standard of care. So everyone with breast cancer would get a sentinel node biopsy. And it's basically used to determine if there's cancer cells in the lymph node closest to the tumor. Primarily used in breast, as I just said. So what happens is I don't know if you guys can see my cursor. So here, where the tumor is, they will inject some dye or some like radioactive material. And then when the surgeon goes to do the biopsy, the idea of injecting the dye is that you're able to see the lymph nodes closest to the tumor. So the lymph nodes will then be removed. They'll be looked under the microscope right then and there. And from there, they're able to see the extent of the surgery that the person would require. If the lymph nodes are positive, then they would often take out the subsequent lymph nodes in the patient's armpit. If the lymph nodes are negative, then they don't need to take out the lymph nodes in the armpit. If it has spread to the lymph nodes, it does not mean that it is metastatic disease. That does not mean that it is spread throughout the body. It just means that it has had local invasion. How else can we diagnose cancer? So we know that we want to diagnose it for the most part with tissue. So some type of biopsy, depending where the tumor is located, how easy it is to get to that. And as I said, the types of biopsies can differ. Your physician will also do a review of your health history. You'll have a physical exam. It's common to have imaging tests. So, an x ray, a PET scan is a nuclear medicine scan where they inject a glucose substance into you. And then the radiologist is able to look to see different areas that have picked up this glucose, a CT scan, an MRI, ultrasound, etc. Other things, so depending on where the issues lie, you can have a colonoscopy. So, a colonoscopy is where they're able to stick a camera in through your rectum. They're able to see the entire large bowel. It also has the ability to cut off any polyps, which are just non cancerous, I guess, little tissue bumps that can become cancerous. Or if there's something of suspicion, they can take a biopsy at that time. There's also something from the other end, it's called endoscopy. It's very similar to colonoscopy, but the camera goes in through your mouth to see your esophagus, which is your swallowing tube, as well as your stomach. Staging. So, once a diagnosis has been made, that is saying that you have cancer. Then from there, the next thing that typically happens is your cancer team will want to do what's called staging. So, it's a uniform and standardized way to describe the extent of disease in your body. So, this is usually done through something called TNM and stages of 1 to 4. They tend to use Roman numerals, which is here my 1 to 4 and the Roman numerals. So, the reason that we want to stage people is that the staging provides information about the size of the tumor, its location, spread to nearby lymph nodes, and whether it has spread, known as metastases, to other parts of the body. Knowing the stage of the cancer helps determine the prognosis, choose the appropriate treatment, and assess the potential for cure. There's lots of different treatments available for different stages of cancer, depending on the type of cancer that you have. So this way, by being able to know exactly the stage, your oncologist or hematologist can pick the appropriate treatment for you. And in Manitoba, we're very lucky. We practice all evidence-based decision making. So we know that the treatment you're receiving is going to be based on large clinical trials that have happened throughout the world. T stands for tumor, and it describes the size. It's usually assigned a number and sometimes a letter. So T1, T2, T3 to indicate the tumor size. T1 would be the smallest, and then you have T3, which would be a larger tumor. The exact specifics varies between the different types of cancer, but all we really need to know is that a T1 is smaller than a T3. N stands for node, and it describes the amount of lymph node involvement. It's typically categorized as N0 or with numbers again of N1 and N2. It would be a grouping of lymph nodes. It wouldn't generally describe just one lymph node. The M stands for metastatic spread, and it describes if the primary tumor has spread and is growing in a distant organ. So, again, that would need to be, if we go back to our example of, let's say, lung cancer, it would need to be lung cells that have moved and are growing in the bone or growing in a distant organ. And again, the metastases will be shown as M0 or with numbers of M1 or M2. We also have the staging then based on the TNM of 1 to 4. So if you are a stage 1, it's usually small and it remains inside the organ that it originated in. If it's a 2 or 3, the tumor is larger or it has grown outside of the original organ into nearby tissue. Stage 4 would be that the tumor has spread to a distant organ and started to grow, and stage 4 is metastatic disease. So it has actually moved to a different site. You may also have a letter attached to the Roman numeral, such as stage 2A, but again, there's slight differences depending on the type of cancer and different nuances. The higher the number, the more advanced the cancer has become. Tumor grading. So we have a lot of factors. We have TNM, we have staging, and then we have tumor grading as well. And as I said, this all goes into determining the best plan of care that is most suitable to you, as well as giving a realistic picture as to predicted outcomes, and to be able to give the doctors and your healthcare team the knowledge to be able to look after you to the best of their abilities. So, a tumor's grade will describe how abnormal the cancer cells look, and they're generally graded from 1 to 4. A grade 1 tumor means that the cells look more normal. So, the cells usually grow slowly and can be referred to as a low grade. Something that sometimes people might hear is they talk about a low grade lymphoma. So, that means that our lymphocytes, which are a type of white blood cell, look very similar to the normal types of lymphocytes, and that type of lymphoma is growing quite slow. A grade 4 tumor means that there are more abnormal cells and often grow quickly and are said to be high grade. If someone has a high grade tumor, it can be more aggressive, but please don't misunderstand. Just because someone has a high grade tumor, they still can, depending on the type of cancer and depending on the stage, it can still be a curable cancer. Other type of staging that you might hear about. So you might also come across terms like in situ. That just means that it's in the remaining in the place, that it has not spread. Localized. So cancer is limited to the place where it started with no sign of spread. So it basically is the same meaning as in situ. Regional. So cancer has spread to nearby lymph nodes, tissues, or organs, but those would still be nearby. distant, so that would be our stage 4, our metastatic spread, where it spread to distant parts of the body, or you could have an unknown, and that means there's not enough information to figure out the stages yet. So you might have initially, when you see the doctor, once you've had a suspicion or a diagnosis of cancer, they'll often from there be able to do the different scans, etc., to look to see exactly if it has spread. So you might have a stage that they might say it's unknown at this time. Tumor markers. So tumor markers are affiliated with different types of cancers. They are able to aid in diagnosis, but they can't make a diagnosis based on tumor markers alone. They often are not that specific to indicate that it's a true cancer. But where you might see tumor markers or where people might follow them is to see how your treatment is going. So, for example, a PSA is something that's used for prostate cancer. So, if you are on a specific treatment for a prostate cancer, your physician might follow your PSA. And if the PSA suddenly starts to rise, it might be an indication that they need to have a closer look to see if you need to switch treatment onto a different treatment or see what's happening. Same idea. Ovarian has CA 19.9 as well, or sorry, CA 125, and CA 19.9 could be pancreatic and colon cancer. So really, it's used just to see how things are progressing along, and it's an indicator that they may need to offer you another scan or to switch treatment. Goals of treatment. I thought I would put this in here. So we have 3 main goals. So that's curative, so control. So control living well with metastatic stage 4 disease. So we have many people that are living much, much longer with cancer that has spread to distant organs due to a huge new number of drugs and different therapies that are available. And the majority of these people are living well, productive, happy lives. Okay. Palliative approach is when we focus on symptom management. So there is such thing as early palliative care, and that can come into play when people are first diagnosed, as well as palliative care throughout someone's treatment trajectory with a main focus on symptom. And if someone is very late stage, they can also help with end of life. Please, it's very important to remember that no two people are the same and people respond differently to the same treatment. Your cancer team works with you to provide care that is based on your desires and wishes. This term is called patient-centered care. And this is really what we strive for, is working together as a combined unit to try and come up with the best plan to achieve the best goals based on you and your family's desires and wishes. And that is my last slide. Oh, take-home messages. My apologies. Cancer is made up of many different diseases that share similar characteristics related to abnormal, uncontrolled way in which the cells behave. Staging a cancer is important as it assists in determining the extent of disease, prognosis, and best treatment options for an individual. And these are my references. And I would love to hear from everyone. Some questions.
All right, thanks very much, Jodi. You know, I've worked in the cancer field for lots of years, but I learn something new every day. So thank you very much. It's always great to reflect on the really core foundational terminology that we use in cancer. I think it's helpful for everybody to sort of be able to speak that common language.
Thanks,
So,
Donna.
all right. So folks that are online, please remember to put your questions in the Q&A box to the right of your screen. And just a note, Jodi, you're getting some kudos in the Q&A, and it's looking very. People are very pleased and found that very informative. You can see there's lots of thumbs up and heart swelling coming up on the presentation. Oh wow! And people are getting really great with the emojis. You saw some celebration wise in that. So
So, thanks, Donna. If I can just add one bit and make a suggestion, especially because it can be quite technical, especially one of the first few appointments, is I really recommend that people bring a notebook or record the conversation on their phone. And if someone has a friend, a family member available, it's great to have a second set of ears. It's so normal to be nervous, and that would go for anybody or anything, especially when you're trying your very best to understand complex information and people are anxious. People just don't remember. And it's not special to CancerCare Manitoba. It could be anything. I mean, I needed to have shoulder surgery. And when I went to go see my surgeon, I was quite nervous. And I came out of there and I couldn't remember half of what he had told me. So that's just one thing I would really recommend to people, because then you can revisit it. And then you can, when you get back in, to know the questions that you want to ask your healthcare team.
thank you, Jodi. I think it's a really good reminder, and I too have experienced that and how important it is. So we have a couple of questions in the chat. One is the first one: should my doctor tell me what all the staging information is?
So your doctor will be, if you ask them, they will be able to tell you what stage you are at. Saying this, depending on the disease that you have, some of the staging might be different. So we know that lymphoma, chronic lymphocytic leukemia, these types of things are staged slightly different. But yes, if you ask your doctor, they should be able to tell you what stage you're at. They should also be able to tell you what if they think this may be a disease that they can cure, a disease they can control, or a disease that you are going to be able to live your best life with.
Okay, thank you. Yeah, I think that's really good information and advice. A second question we have is, when should we expect to hear from our oncologist officially that we're cancer free?
Thank you. I can see it's from Rosita. So thank you, Rosita. I wish I could give you concrete answers, but unfortunately, because the cancer consists of, as we saw in the definition, from 100 to 200 different diseases. It's going to vary again from disease to disease. I believe the working definition is when you have been in remission or cancer free for 5 years. Depending on the specific disease, you could be considered to be sort of cured. Why do we use the 5 year mark? Because for many diseases, if it is going to come back, it would come back within that period of time. But typically, your physician can tell you if you had an operation to cut the cancer out, they can tell you that from what they see, they were able to remove the entire tumor. The other thing that they can tell you is they can tell you from the scans, there appears to be no cancer that we can see, or from the blood test, again, depending on your disease, it appears as though there is truly nothing there. But it's very hard to be able to say 100% exactly that you're 100% cancer free and you are officially cured until you've gone that period of time. But they can definitely give you good news that there is no evidence of disease.
Yeah, I think there's often signposts along the way that are sort of signposts of good news,
Good
which can,
news, definitely.
yeah, that's great. So a follow-up question, what about, how come patients' immune systems go up and down? What makes that happen?
So so there's lots of reasons why people's immune systems go up and down. So we could start right from the beginning with like the diagnosis of cancer. So for whatever reason, our bodies did not recognize a cancer forming, and the cells ran away on us and they formed a tumor. Okay. Next thing we know is cancer can sometimes make our own immune system invisible, or they can make themselves invisible, and therefore our immune system is not able to see the cancer once it's developed, and the cancer is able to grow. Next, depending on the treatment that you have, we know that both chemotherapy, and some radiation therapy, depending where the beams are going, can affect our immune system, because our immune system, our fighting cells, live in adults in our hips. So if we have drugs that affect basically fast growing cells, so that would traditionally be chemotherapy, or we have radiation that is aimed at sort of our hip area, that our infection fighting cells go down. And then our immune system would decrease for a period of time. But these types of cells are regenerative, so then it would go back up again. I don't know if that really answers the question. Hopefully, that's an okay answer. Um, is that okay, Rosita? Does that somewhat answer the question?
All right, well, we'll wait for her follow-up response, but maybe just while she's thinking about that and others are thinking about that, a couple of other questions. One is regarding patients who are in the north of the province, and what's the, there are not specialists quite so much in the north. So what happens if a patient gets referred to a doctor that doesn't specialize in cancer for treatment plans, and how does that work?
So, thank you, Jason, for asking this question, because I absolutely love this question, because I am so pleased and so proud to say that CancerCare Manitoba is a provincial agency, and we have what's known as a shared care model. So, every single Manitoban that has a suspicion or a diagnosis of cancer will see a specialist. And then what we're able to do, once the specialist, so that would be an oncologist, a hematologist, a radiation oncologist, would be able to plan the care, and then the patient is able to return to their community closer to home and work in very close succession under a care team known as the Community Cancer Program. So these physicians and nurses that work in the community cancer programs have been specially trained to be able to care for people and work in combination with the specialists located in Winnipeg. We have a center in Thompson, a center in Flin Flon, as well as a center in the Paw. And so everyone has come for additional study to be able to fulfill this care. And you're still under the care of the specialist. And if there's ever concerns, questions, or just wondering what to do next, then that specialist is consulted. So you are definitely not left on your own with an untrained care team. So the care and should be as good, if not better, because you're closer to home with the people that you love and the people that love you.
Yeah, thanks, Jodi. That's really good. That's a good note. So we have a really good system here for that partnership.
Excellent.
I think we have more time to squeeze in one more question. Could you explain just the term invasive? What does that mean?
So invasive means that it has moved, or it is grown into another space. It's like it's invaded, would be sort of, I guess, the term of invasive. So if you have a invasive cancer, it means that it may have moved. Doesn't mean that it has necessarily spread, but it has moved from the original sort of space. So a good example would be breast cancer. So we know with breast cancer, the most common type is something called an invasive ductal carcinoma. So, what that means is the breast cancer has started growing in the milk duct. Well, I'm not sure how big a milk duct is, but I think it's probably very, very small. So, if you have an invasive ductal carcinoma, it just means that the tumor has spread outside of the milk duct into the surrounding area in the breast. It does not necessarily mean that it has traveled anywhere else.
Awesome. Thanks very much, Jodi.
Thank you very much, Donna. Thanks, everybody.